Welcome to Future Frontlines, the podcast from Vespia, the Veterans, Emergency Services and Police Industry Institute Australia. Future Frontlines is where we talk about the things that matter in the defence, veteran, emergency services and policing sectors. The evidence, the policy, the people doing the work, and the conversations the sector needs to be having. We run 5 series on this feed. In Chambers brings you into conversation with the ministers, senators, and parliamentarians shaping policy for this sector. In the Field puts a spotlight on the practitioners, advocates, and organisations doing the work on the ground. Sector Dispatch is where I break down what's happening in policy, legislation, and research, and what it actually means. Research and Evidence translates academic and policy research into plain language for a practitioner audience. And Expert in the Room brings in specialists, cross-sector voices, and international perspectives. Whatever series you're listening to, welcome. If you want to find out more about Vespia, explore our research library, or find out how to become a member, head to vespia.org. A quick note before we get into the detail. The information in this episode is general in nature and is based on publicly available sources, official government communications, and perspectives shared by sector practitioners. It's designed to give you an overview, not personal, legal, financial, or claims advice. Individual circumstances vary significantly, particularly when it comes to anything touching on DVA entitlements, compensation claims, or legal matters. If any of what we discussed today is relevant to your specific situation, please speak to a qualified professional, a registered advocate, a financial advisor, or a lawyer, depending on what you need. Welcome back to Future Frontlines. I'm Shannon Hennessy, CEO and founder of Vespia, and this is Sector Dispatch. And today I'm covering 2 things that are happening in the same few weeks and I think need to be understood together and not separately. First, the 2026-27 federal budget handed down on the 12th of May. There are significant measures for veterans and the defence workforce in there. There's also a contested savings measure that the sector has pushed back on hard, and a funding cut that blindsided some of our most effective veteran rehabilitation programs, and a gap in the fee schedule that still hasn't been addressed. I want to give all of that the honest treatment it deserves. Second, the MRCA reforms, formerly the Veterans Entitlements, Treatments and Support Simplification and Harmonisation Act of 2025, known as the VETS Act, which will take effect on the 1st of July 2026. This is the most significant change to veteran compensation legislation in Australia's history. If you work with veterans or you are one, you need to understand what's changing before that date. Both of these sit within the same story, the Royal Commission into Defence and Veteran Suicide, and what implementing its recommendations actually looks like in practice. Understanding that context is, I think, essential to reading both of them clearly, including the parts that are genuinely good and the parts that want scrutiny. Before I get into the detail, a very quick but important caveat. Claims advocacy is not my area of expertise. I am the CEO of a professional body, not a registered advocate, and I want to be clear about that. What I'm covering today is drawn from government announcements, budget papers, official DVA communications, and the views and sentiments of members of our community who work in this space every day. People who understand the system far more deeply than I do from the inside. This is just an overview. It's meant to give you a clear picture of what's come from the government and what the sector is saying about it. It won't reflect every individual perspective, and there are nuances, particularly around individual claims decisions that are well beyond what I can speak to authoritatively. What I can tell you is that we will be bringing the experts in. Over coming episodes in our In the Field and Expert in the Room series, you'll be hearing directly from advocates, practitioners, and people who live and breathe this system. Today is the overview. The depth, well, that comes next. All right, let's start with the budget. Before I go through the specific measures, I want to spend a few minutes on context, because how you read this budget depends entirely on what you think it's responding to. The Royal Commission into Defence and Veteran Suicide ran for nearly 3 years. It heard from thousands of veterans, families, advocates, researchers, and service providers across Australia. It released an interim report in 2022 and a final report in September of 2024. Together, those reports made 122 recommendations, a comprehensive, evidence-based blueprint for what needs to change across the veteran support system, defence culture, mental health access, and the compensation framework, and a whole lot more. The government agreed in principle to 104 of those 122 recommendations. It noted 17 for further consideration. That response was described by the government as the most comprehensive reform ever undertaken to the systems, culture, and processes across defence, the ADF itself, and DVA. That's a significant commitment, and the 2026-27 budget is a significant tranche of it being resourced. The headline number the Treasury used in the budget speech was almost $800 million for veterans as part of the Royal Commission response. That's the frame the government is using, and I want to hold on to that frame as we go through specific measures, including the parts that don't sit as neatly within it. The total DVA allocation for 2026-27 is $5.7 billion to support the health, well-being, and care of eligible veterans and their dependents. And that's the base. The new measures we're talking about today sit on top of that. One more bit of context worth noting, the 2025-26 Mid-Year Economic and Fiscal Outlook, the MYFEO, had already committed $590.5 million over the next 3 years from 26-27 to deliver innovative and evidence-based treatments to veterans, including specialised treatment for conditions such as PTSD. That announcement predates this budget. Today's measures are additional to that. All right, let's go through them. Allied health provider fees. $169.7 million over 5 years, $58.8 million per year ongoing from July 1st, 2027. This is the largest investment in veteran allied health provider fees in more than 20 years, and it responds directly to Recommendation 71 of the Royal Commission. To understand why it matters, you need to understand the access problem it's trying to fix. One of the most consistent barriers veterans face in accessing mental health and allied healthcare is that providers could treat them, such as GPs, psychologists, physiotherapists, occupational therapists, exercise physiologists, podiatrists, and others are choosing not to take on DVA patients. Not because they don't want to help veterans, but because the fees that DVA pays have fallen significantly behind what these providers can earn from Medicare or private billing. The practical result is that a veteran with a gold card or white card may technically have access to these services, but find in their area, very few providers are accepting DVA referrals. The card exists, but the care doesn't. Higher fees should help close that gap. The fee increase will apply to a broad range of services, including psychology, physiotherapy, occupational therapy, exercise physiology, podiatry, social work, and speech therapy. It does not include dental, optical, or hearing services, or medical or special services, and I'll come back to that last point shortly. This is a genuine, significant investment. The allied health access problem has been documented in submission after submission, inquiry after inquiry. That it's finally being funded is welcome. I'll come back to the important caveat on this measure in a moment, and there is one, and it is significant. But first, moving to the National Veterans Data Asset. $29.8 million over 3 years from 2026-27. This establishes a comprehensive data infrastructure, bringing together information from defence, DVA, state and territory sources. It responds to Recommendation 107 of the Royal Commission, which called for the establishment of a national data asset to better inform policy, service delivery, and program evaluation. The NVDA will also support the implementation of further Royal Commission recommendations, including informing Comcare's regulatory approach to preventing psychological harm, enabling research into the health and well-being of defence families, and supporting the new Veteran and Family Wellbeing Agency in co-designing programs. From a VESPIA perspective, this matters because the quality of policy is only as good as the evidence that it's built on. One of the consistent frustrations in this sector is that we keep conducting inquiries that rediscover the same problems, in part because we don't have longitudinal linked data that allows us to track whether anything is actually improving. A properly resourced national data asset is the foundation for that. It also means that in 5 years' time, when someone asks whether the Royal Commission recommendations actually changed outcomes for veterans, we'll have the data to answer that question. That accountability mechanism has been largely absent from previous reform cycles. Next is the provisional access to medical treatment extension, $3.4 million over 2 years from 26-27. This extends the Provisional Access to Medical Treatment Program, PAMT, to December 31, 2027. It responds to Recommendation 96 of the Royal Commission. PAMT allows eligible veterans to access DVA-funded medical and allied health treatment for the 20 most commonly claimed conditions while they're waiting for a liability determination on their claim. The key word there is waiting. Claims processing takes time. A veteran with a physical injury or a mental health condition that is almost certainly service-related should not be waiting in pain or without mental health support while that administrative process works its way through. The principle PAMT embeds is important. The obligation to provide care doesn't pause while the bureaucracy processes the paperwork. This extension keeps that principle funded for another 18 months. Moving to military sexual violence inquiry, $16.6 million. This funds the Independent Defence and Veterans Service Commission to conduct a public inquiry into military sexual violence in the ADF from mid-2026. The report recommendations will be made public. The evidence of systemic failure in how sexual harm is handled in defence environments is extensive. The Royal Commission documented it. VESPIA's own Women in Service paper documented it. Multiple internal reviews over decades have documented it. What's new here is an independent inquiry with a specific mandate, public reporting requirements, and dedicated funding. And that structure matters. Independence matters, and public accountability absolutely matters. But what's also important here, and this is something that VESPIA will be watching very closely, is whether this inquiry produces structural accountability outcomes or whether it becomes the latest in a long sequence of reviews that are received, noted, and set aside. The RSL has consistently argued, and VESPIA agrees, that support for a statutory independent oversight body with ongoing authority is what the evidence requires. A time-limited inquiry is a necessary step. It is not sufficient on its own. Next up is the Veteran and Family Wellbeing Agency, $78 million over 4 years, launching July of 2026. This agency launches in July, responding to Recommendation 87 of the Royal Commission. Its focus is veteran transition, community connection, and wraparound support, particularly for veterans at highest risk during and after transition from service. The Royal Commission was unambiguous about where the greatest risk sits. The veterans most vulnerable to suicide are those who transition out of the ADF involuntarily through medical or disciplinary grounds, not those who chose to leave after a fulfilling career. The agency's focus on transition is directly targeting what the evidence identifies as the highest risk point. The Natural Veterans Data Asset we just discussed is directly connected to this agency's work. It will support the Wellbeing Agency in co-designing programs based on actual population data rather than assumptions. That link between data infrastructure and service design is how you build a system that learns and improves over time, rather than one that keeps repeating the same mistakes. The structure, remit, and independence of this agency will be important. The appointments, the governance arrangements, the clarity of its mandate, all of these will shape whether it fulfills what the Royal Commission had envisioned. It's worth tracking closely over the next 12 months. Next is the Prime Minister's Veterans Employment Program, $500,000 in 26-27. This is a relatively modest figure. Veteran employment, helping people leaving service find meaningful civilian careers that match their skills and expertise, is one of the most effective things we can do for veteran well-being. Employment provides structure, identity, purpose, and financial security. The research on this is consistent. $500,000 for a national program is not a serious investment in veteran employment. For context, organizations working in this space at scale need multi-million-dollar funding to maintain the outreach, case management, and employer relationships that make employment programs work. This figure doesn't match the documented need, and it's worth naming that clearly. Now, these are the positive measures in the budget. There is real and meaningful investment there. So let's now talk about the parts that the sector has pushed back on, because the pushback is legitimate and it deserves the same honest treatment. The $5,000 annual monetary limit on veterans' allied health services and $779 million in savings. From 1st of July 2027, veteran cardholders will have a cap of $5,000 per year on allied health services. DVA has confirmed that a mechanism will exist to fund services above the cap where there is a valid, ongoing clinical need. Consultation on the implementation arrangements will happen in the second half of 2026. Now, the treatment cycle requirement is also being removed at the same time, which is a genuine simplification. Previously, veterans needed to manage treatment cycle paperwork to access ongoing care. That administrative requirement is gone from July 2027, and that is a positive change. The government has stated the rationale for the cap is to address overservicing in the system, instances where providers are ordering more treatment than is clinically necessary because there's no financial ceiling. And that's a legitimate system integrity concern. It does exist, and the government is not making that up. But here's the number that puts the cap in a different line. The savings generated by this measure are $748 million over 3 years from 27 to 28, and $340 million per year ongoing. And that is a very large savings measure. And those savings go back to consolidated revenue. The total savings from all veteran support changes in this budget are close to $779 million over 5 years. RSL Australia, which welcomed the allied health fee increase as long overdue, was direct about the tension this creates. The National President, the Honourable Peter Tinley, said the budget represented a mixed outcome for the veteran community. His specific concern was that many veterans live with complex and chronic physical and psychological injuries arising from their service. For those veterans, ongoing physiotherapy, psychology, exercise physiology, and other allied health treatments are not discretionary. They are essential to daily functioning, recovery, and their quality of life. A $5,000 cap is not a lot when you're a veteran managing multiple service-related conditions simultaneously. A psychologist appointment alone can run $250 or more. Physiotherapy, exercise physiology, occupational therapy, those costs accumulate quickly. The Families of Veterans Guild was more direct still, describing the cap as blunt and poor policy. They raised a concern that the cap may inadvertently increase the burden on families, that veterans who hit the limit will turn to family members for support and care rather than professional services. It's a displacement of cost onto the people least resourced to absorb it. And surprisingly, Contact Magazine's assessment was the sharpest of all. Their position, after the Royal Commission, veterans were promised structural reform. What they got instead was a system that introduces a cap on the services they were told they'd have better access to, lets other supports remain temporarily or conditional, and doesn't address the gaps in the GP and specialist fee schedule. Last point is one that RSL Australia has also raised, and it's worth unpacking. The allied health fee increase applies to physiotherapists, psychologists, occupational therapists, and similar providers. It does not include GPs or medical specialists. The access problem for veterans trying to find GPs and specialists who will bulk bill under DVA arrangements remains entirely unaddressed in this budget. The fee schedule for medical services hasn't been reviewed, and that's a significant gap, and the sector has named it clearly. Vespia's position is this. We hold the principle that access to care for service-related conditions should be clinically determined, not administratively constrained. The exception mechanism exists, and DVA has confirmed veterans with genuine clinical need will not be cut off. But the design of that exception mechanism, how veterans apply for it, how decisions are made, how long the process takes, and whether the threshold is calibrated appropriately for complex needs veterans, will determine whether the principle survives contact with reality. The consultation process in the second half of 2026 is the opportunity to shape these arrangements. Vespia will, of course, be engaging with it, and I'd strongly encourage our member organisations and sector stakeholders to do the same. Moving now to the next point of contention around Invictus Australia and Kookaburra Kids, the complete withdrawal of federal funding. This is the budget measure that I want to spend probably the most time on because it received the least proportionate coverage, and it represents something really important about the gap between what the Royal Commission called for and what this budget delivers. The 26-27 budget completely withdrew all government funding for Invictus Australia's national veteran support and rehabilitation programs and for Kookaburra Kids, the organisation that provides camp-based support programs for children whose parents have a mental illness, including children of veterans and first responders. To our knowledge, neither organisation was properly consulted. Invictus Australia was informed less than 2 hours before the budget was handed down with no transition plan, no winding down arrangement, no acknowledgement of the programs that they run and the people who depend on them. Let me be clear about what these organisations actually do, because both names can be misread as peripheral and they aren't. Invictus Australia has supported close to 30,000 veterans and family members through community sport and rehabilitation programs delivered across Australia. Their chief executive described it directly. Invictus Australia is not a recreational outlet. It is a lifeline. For many of their participants, those programs are how they manage PTSD, anxiety, and depression, how they rebuild routine and purpose after leaving service, how they reconnect with communities, and how they navigate the transition from military to civilian life. Kookaburra Kids works with the children of those families, the ones growing up alongside a parent managing service-related mental illness. The evidence on intergenerational trauma in defence and veteran suicide is well established. Supporting children through that experience early is one of the most effective long-term interventions available. Kookaburra Kids does that work, and their funding is gone. The Royal Commission's evidence base is unambiguous about the importance of community connection, purpose, and early intervention in veteran wellbeing and suicide prevention. Both those organisations' program models are directly aligned with what the Royal Commission found works. At a time when Australia continues to confront the ongoing rate of veteran suicide, the Australian Institute of Health and Welfare has documented at least 1,667 suicides among serving and ex-serving personnel between 1997 and 2021. These are not peripheral programs, they are frontline ones. And they were cut without consultation, without transition, in a budget that the government is describing as its most significant Royal Commission implementation investment ever. Vespia absolutely views this as a serious misstep, and we will be saying so. These funding decisions sit in direct contradiction with the evidence the Royal Commission produced. Now, before I move on, I need to do a quick update. And for those of you watching in the video, you'll notice quick costume change. In the time between recording this and getting the episode up, both Invictus Australia and Kookaburra Kids have had their funding restored. I'll be honest, I almost cut this section entirely, but I decided to leave it in because I think the original decision still matters. The fact that funding was stripped from these organisations without consultation, without transition planning, in a budget that the government has described as the most significant Royal Commission implementation investment ever, happened. And the sector's response to it also happened. What we saw in the days after the budget was organisations, advocates, veterans, families, and sector bodies making a lot of noise, very loudly and very quickly. And the funding came back. That's community organising and community advocacy working exactly as it should. I'm genuinely thrilled for both organisations and for the veterans, families, and the kids who depend on what these organisations do. So rather than this being a cautionary tale, let's call it what it is. It's a demonstration that when the sector speaks with one voice, it gets heard. So let's hold on to that. Now, back to the episode. Now, with all of that, I want to step back and try to read all of this as a whole because I think the context matters here. The positive case for this budget is real. The allied health fee investment is the largest in 20 years, and it directly addresses a documented access problem. The data asset is the foundation for evidence-based policy that this sector has needed for years. The PAMT extension keeps care accessible during claims processing. The Wellbeing Agency launching this July is a tangible Royal Commission outcome. The military sexual violence inquiry is funded and independent. These are not nothing. They are, in many cases, the things the sector has been advocating over years and decades for. The critical case is also real. The $779 million in savings over 5 years from veteran support arrangements, largely from the allied health cap, is a large number sitting alongside a smaller investment. The treatment of that savings figure in government communications has been minimal. It deserves to be front and centre in any honest accounting of what this budget does. The Invictus Australia and Kookaburra kids defunding without consultation and without transition support directly contradicts the evidence the Royal Commission produced. It is inconsistent with the government's stated commitment to implementing that evidence. The GP and specialist fee schedule remains under reviewed. Veterans who can't find a bulk billing GP, and there are many of them, don't benefit from allied health fee increase if they can't get the referrals to access those services in the first place. The Veterans Employment Funding is inadequate for the scale of need. What this budget is, a genuine but uneven tranche of Royal Commission implementation with some meaningful investments and at least one significant misstep. A savings measure that will test the government's stated commitments in practice and gaps the sector has named clearly. And that's an honest read. And it's the read Vespia will be working from as we track implementation over the next 12 months. Right, so with the budget covered, let's move to the MRCA reforms. The legislation is the Veterans Entitlements, Treatment and Support Simplification and Harmonisation Act of 2025, the VETS Act. It was passed by Parliament on the 13th of February 2025 and takes effect on the 1st of July 2026, just 4 weeks from now. Before I explain what changes, I want to spend some time on the problem it's solving, because history matters and because understanding it helps you understand why simplification is not just a bureaucratic improvement, but a welfare and safety issue. For decades, Australia's compensation and rehabilitation system operated under 3 separate acts of Parliament. The Veterans Entitlement Act, or the VEA, covers veterans with service generally from the Second World War through to 1994 and certain later service. It was designed in an era where the veteran population was predominantly older men with service in major conflicts. The Safety, Rehabilitation and Compensation Defence-Related Claims Act, or the DRCA, covers ADF members who suffered injury, disease or death related to service from the mid-1980s through to 2004. And the Military Rehabilitation Compensation Act, the MRCA, introduced in 2004, covers service from that date forward. 3 acts, 3 sets of rules, 3 different assessment frameworks, different entitlements, different payment structures, different standards of proof, different rights of appeal, different pathways to gold card coverage. A veteran who served across multiple time periods might have their entitlements governed by different acts for different conditions. An advocate trying to help someone navigate a complex claim might need to hold all 3 frameworks in their head simultaneously. DVA staff processing claims work across 3 different legislative environments, and the person at the centre of all of this, the veteran with a service-related injury or illness who needs support, is expected to navigate it. The Royal Commission's interim report in 2022 named what this complexity was doing. Their finding was direct, and I'll quote it. The legislation governing compensation and rehabilitation for veterans and families is so complicated that it adversely affects the mental health of some veterans and can be a contributing factor to suicidality. The system designed to support veterans was itself causing harm. And that is a remarkable finding, and it's the problem that the VETS Act is designed to address. From the 1st of July 2026, the VEA and DRCA closed to new claims for compensation and rehabilitation. All new claims lodged from that date, regardless of when a person served, will be assessed under a single, improved version of the MRCA. 1 act, 1 set of rules, 1 assessment pathway. That is the core change. Everything else flows from it. What does not change, and this is important, if you are currently receiving payments or entitlements under the VEA or DRCA, those are grandfathered. They continue. They continue to be indexed and adjusted in the normal way. You don't need to apply for anything. You don't need to notify DVA of anything, and nothing is taken away from you. I want to be completely clear about this because misinformation in this space causes real and unnecessary anxiety for veterans and their families. No veteran will lose current payments or entitlements as a result of the Vets Act. The transition only affects new claims lodged from the 1st of July 2026 onwards. So now looking at the improvements for current DRCA veterans. Veterans currently receiving incapacity payments under the DRCA will automatically transition to the improved MRCA scheme from 1 July. Because the MRCA is more generous, this is a financial improvement. You don't need to apply, it happens automatically. DRCA veterans will also gain for the first time the right to appeal DVA decisions to the Veteran Review Board. That right of review has not been available under the DRCA. It will be from the 1st of July. If you're a DRCA veteran who has previously been unable to challenge DVA decision through independent review, that changes in 4 weeks. DRCA veterans will also now have a pathway to the Gold Card, the DVA card that covers the full cost of all health conditions, not just service-related ones. There was no Gold Card pathway under the DRCA, and now there will be from the 1st of July. Looking at specific practical improvements, the 50-kilometre travel minimum is now removed. Under the existing system, veterans needed to travel at least 50 kilometres round trip to be reimbursed for travel to treatment. From the 1st of July, all treatment travel is reimbursed at the MRCA rate, regardless of distance. For veterans in regional, rural, and remote areas for whom these services they need are really next door, this matters significantly. A new additional disablement amount is being introduced for veterans of pension age with a high degree of impairment due to service cause conditions. This is similar to the extreme disablement adjustment that already exists under the VEA and provides additional financial recognition for veterans significantly impaired by service. The definition of service injury is being expanded to include injury sustained while on duty, including cardiac events like heart attacks and strokes, regardless of whether the ADF's specific duties at that moment were the direct cause. This is a meaningful broadening of what can be accepted as service-related. The existing treatment cycle, referral requirements, the administrative process that required ongoing paperwork to maintain access to an allied health treatment are being removed. As I mentioned in the budget section, this is connected to the new annual monetary limit. Both changes take effect from 1st of July 2027 for the allied health cap and 1st of July 2026 for the broader legislative reforms. So what does this mean for people navigating the system? If you're a veteran who has conditions that haven't been claimed yet, particularly conditions from service before 2004 that might have been covered under the VEA or DRCA, there is a genuine question worth working through before 30 June. Under some circumstances, lodging a claim before the 1st of July under the current acts may produce a different outcome than lodging the same claim after the 1st of July under the MRCA. The MRCA is generally more generous, but individual circumstances may vary, and the interaction between different acts, different service periods, and different conditions is exactly the kind of complexity that requires a trained advocate to navigate properly. I would strongly encourage anyone in this position to get a qualified, registered advocate before the end of June, rather than making that decision without advice. The DVA Advocacy Register, available through the DVA website and searchable by location, is where you find accredited advocates. This is precisely what they are there for. For organisations and practitioners working in veteran services, the people you support will have questions about this. Some of those questions will be straightforward and some will be significantly complex. The key messages are consistent. Existing entitlements are protected. New claims go through the improved MRCA. The system is simpler, but navigating it still benefits from advocate and support. Anyone with unclaimed conditions should get advice before the 1st of July. So I want to now close the substantive part of this episode by saying something about what the budget and MRCA reform represent together and what they don't yet represent. The Royal Commission ran for 3 years. Its work was the result of years of advocacy by veterans, families, and sector organisations who refused to let the systematic failures that had caused harm for decades go unaddressed. When the government accepted 104 recommendations, the expectation was that structural change was coming. What we're seeing now is what implementation looks like, and implementation is always messier, more contested, and more incremental than the promise that preceded it. The allied health investment is real. The Wellbeing Agency is real, and the Vets Act is real, and it is significant. The data asset is real, and these are funded, legislated, or operational commitments that will make a difference to real people. The savings measures, the Invictus and Kookaburra kids defunding, the GP fee gap, the inadequacy of the employment program, these are also real, and they are not consistent with the full weight of what the Royal Commission has called for. Vespia's role in this environment is not to applaud or to condemn, but to hold the line on outcomes. Not whether money is announced, but whether the experience of veterans, families, and first responders is actually changing as a result of what's been funded. And that's what we'll keep doing. And that's exactly what Future Frontlines is here for. Before I sign off, I want to leave with the practical takeaways. If you're a veteran currently receiving DVA payments or entitlements, nothing changes. Your entitlements are grandfathered and you don't need to do anything. If you have service-related conditions that haven't been claimed yet, consider getting a qualified advocate before the 30th of June to understand whether to lodge now or after the 1st of July. The DVA Advocacy Register is available on the DVA website and is searchable by location. If you work in veteran services, advocacy, or support, understand the Vets Act changes well enough to answer basic questions from the people you support. DVA has a plain language fact sheet on their website, and I have linked them in the show notes. If you have concerns about the allied health cap, the consultation process happening in the second half of 2026 is the mechanism for shaping how the exception process works in practice. Absolutely engage with it. Encourage your members and your stakeholders to engage with it. And if the Invictus Australia and Kookaburra kids defunding matters to you, and I think it should, make that known through your networks, your members, and your representatives. We hope that this decision can be reversed, and sector pressure is the mechanism for that. Links to the DVA budget fact sheets, the Vets Act resources, and the DVA register are now in the show notes. I'll close with what I said at the end of the Women in Service episode because it applies here too. The people who contributed to the Royal Commission's evidence, who gave testimony, who shared stories, who advocated for years for the sector to take this seriously, did that at significant personal cost. The work of holding implementation to account is the continuation of what they started. It matters. Keep doing it. I'm Shannon Hennessy. This is Future Frontlines. Thank you for listening. That's it for this episode of Future Frontlines. If what you heard today was useful, please share it. The people who need to hear these conversations are often the ones who won't go looking for them. Please put it in front of someone who works in the sector, someone who supports veterans or first responders, someone in policy or government who should be listening. If you'd like to support the work Vespia does, the research, advocacy, events, and the connections we build across the sector, the best thing you can do is become a member. Membership is open to organisations and individual professionals working anywhere across the sector. Head to vespia.org to find out more. You can follow Vespia on LinkedIn for updates between episodes or subscribe to our Field Notes newsletter. The link is in the show notes below. And finally, if you've got someone in mind who should be on this podcast, a practitioner, a researcher, policymaker, someone who is doing work the sector needs to hear about, please do reach out. You can get in touch through the website or find us on LinkedIn. I'm always looking for the next conversation. Thank you for listening to Future Frontlines.